All right, good morning, everyone. This is a joint meeting of Senate Health and Welfare and House Healthcare. I'm Senator Ginny Lyons, Chair of Senate Healthcare, Health and Welfare. And Bill,
Good morning, Bill Lippert, Representative Bill Lippert, Chair of the House Healthcare Committee.
So this morning we're very pleased to have with us Susana Davis and others who have completed work on our report, our diversity report in healthcare. So I don't want to spend a lot of time talking before we jump right into hearing from you, Susana, and the other folks with you, and ask you how will you go through the testimony? Are you going to share the testimony, or do you want to go in order?
Thank you. Good morning. I had hoped just to speak very, very briefly and then turn it over to Andrea and Mark to add fill in any gaps that I may have missed. So
sounds perfect. Just as an FYI for you folks, Senate Health and Welfare will need to leave at 10 o'clock. And if House Healthcare has additional questions, they may be able to sort that out until about 10:15. We do have a joint meeting on the floor of at 10:30. So just some timing issues, and we'll try to keep you informed as we go along. Okay, so please introduce yourself for the record, and we're very happy that you're here and look forward to the report.
Thank you. For the record, Susana Davis, Executive Director of Racial Equity for the state of Vermont. I have 6 slides for you, so I hope I can get through them quickly. And I just want to confirm if I can share those or if I should ask the—
Yes, you can.
Yeah,
okay. Well, there's can, right? We'll see if this works.
Let's see. Turn it up just a little bit.
All right, you should be able to see my screen.
Yes.
Great.
Okay.
So
I'm going to ask, if you're not speaking, to maybe mute yourself. I think the committee room is coming through.
Oh.
Okay.
yeah, you can press that.
This is the logistics of hybrid. Okay, Susana, sorry for the interruption. Why don't you go ahead?
All right, thank you. So I can only see one of you, so please do feel free to stop me with any questions or if you need me to repeat something. So we are here today to discuss the Health Equity Advisory Commission, and I might refer to that as the HEAC heretofore. The HEAC's report, it is the first report which was originally due to be filed on January 15th of this year. The committees were gracious enough to give the commission a bit of an extension, and I'm going to discuss why that was requested and what it meant for us. So first, I will begin by giving you a little bit of background about how this commission has been set up. So it is a whopping 29 members large and includes representatives from state agencies, including the Department of Disability, Aging, and Independent Living, DCF, that's Department of Children and Families. It includes representatives from Agency of Administration, of course, that's Racial Equity Office. It also includes community partners and not-for-profits and community organizations, including the NAACP, the Racial Justice Alliance, Outright Vermont, the Commission on Native American Affairs, plus representatives from each of the state-recognized Abenaki bands. It's a very large group, and we are extremely fortunate to have that breadth of expertise in the room. So with a large scope and with a large group, one of the early decisions that we made was to break our work down into 7 main components and to create subcommittees aligned with those components. You'll see those described on the screen. Our subcommittee structure allows us to be able to take smaller bites. This is a very large sector of work that we're looking at. There are people who spend entire careers working full-time and around the clock to be able to figure out and think through some of the things that we're asked to think through here. So you'll see that these committees range from access to care to policy, training, external engagement, data, upstream factors, grants, etc. This covers a lot of the tangible duties that we as a commission are asked to perform, such as the distribution of grant funding, and also covers some of the more theoretical and policy-related matters, such as upstream factors and social determinants of health, which are going to lead us to topics that may not fit directly with health or the healthcare delivery system, but which certainly have impacts on individual and public health. So the commission is at a point right now where we are still standing up these subgroups. But before we got started on the subgroups, we did have a number of discussions as a larger group where we figured out, hey, you know what, this is a really big scope, and we want to make sure that we do this correctly. In the room, you have people who are in high-ranking roles of government, people who are in supervisory or managerial positions, people who are advocates. Some of us are invited into many spaces, and others of us struggle to bring our folding chair to the table, so to speak. And so with that wide of an experience, we wanted to make sure that we did some level setting and try to model process equity as much as we could. Now, we're not there yet. It's certainly not perfect, and we're still having ongoing discussions about how we can make our group and its experience more equitable. But some of the things that we have agreed on and landed on early include things like accessibility policy for our meetings. It includes things like making sure that our documents are formatted in a way that is accessible for people who may be visually impaired. It means that we have a team of people who are dedicated to engagement and communication should we receive inquiries from members of the public, members of the press, members of government, etc. All of these things contribute to a broader goal of process equity. It's not just about making sure that we arrive at the correct conclusions, but about making sure that we didn't step on anyone while we got there. Now, the way that you go about it is one thing, but what we have to work with and what we have to talk about is quite another. One of the earliest findings that we arrived at was about data. We hear the same story in every sector imaginable, especially when it comes to equity. We have some data, it's not great. We need more data, it has to be better. We've got to collect it better, more consistently. We need the technology. All of these things are true in the health equity space as well. And in addition to those things, here are a few other challenges that have made our data situation a little bit more fraught. We know that historically, and this is centuries and centuries, medical research has tended to focus on people in dominant groups. A lot of what we know about health and medicine is because of work that has been done that centers able-bodied people, male-identified people, and people of European descent. What that means is, and I'll give you one example, and I think this example might even be in the report. If you ask somebody, what are the signs of a heart attack in progress? They might tell you, oh, left arm situation and whatever else. As a matter of fact, that is a symptom, that is a sign that is common in men, but not in women having a heart attack. But many people don't know that. The fact is, a lot of what we know or what we think we know about health and medicine centers people who have historically been in positions of power. Here's another example. Early on during COVID-19, we were looking for symptoms and telling people what was the short list of things to look out for. One of those things that we said to look out for was, if you see discoloration around the lips, maybe if your lips are looking blue. Well, if you're a dark-skinned person, your lips may not appear blue. And if the guidance that we're putting out tends to center people with light-colored skin, then, well, we're effectively excluding other people from being able to timely detect things like COVID-19 symptoms. So we know that medical research has tended to focus on able-bodied, male-identified, and European-descended people. And we also know that a lot of the more painful medical research has been done on, well, everybody else. Think of the more harrowing experiments that have happened over the years. We always talk about Tuskegee, but there's so much more, unfortunately, that's been inflicted on our community. We know that, for example, J. Marion Sims, who's regarded as the so-called father of gynecology, did a lot of his work on Black and brown women And it was grossly painful, often without any sort of anesthesia. Of course, no crediting or further assistance to the families or to the patients. We know that the experience of people like Henrietta Lacks, which touches on issues not just of medical ethics, but also things like intellectual property and ethics in the way that we communicate about diseases. We know that in Vermont, we have a deep and extremely disturbing history of eugenics. And what's important to note here is we often talk about eugenics in Vermont as being directed at Indigenous people, and that is very much true. But it also had an incredibly deep impact on the community of people living with disabilities, who are also a major target. As a result, when we talk about things like trust, and I'll come back to trust in a moment, when we talk about things like trust, people living with disabilities, people who are Indigenous, and really the rest of us, all have the memory that is longer than our lifetime, right? The intergenerational trauma that these things have brought. I'll continue. We know that in the United States, women have been sterilized in carceral facilities as conditions of release. As recently as 2 years ago or last year at the southern border, involuntary hysterectomy of migrant people. We know that on Puerto Rico, the United States was also sterilizing a lot of women. So when we think about the need for collecting data, so much of data requires the participation of individuals in the public. Collecting data about me requires some level of my participation. Although the way the police state of the United States is shaping up, soon you won't even need me to participate. You'll have everything you need. Regardless, where we are right now, you've got to have some level of participation from the individual, him, her, or themselves. However, because of the history of medical research and experimentation, those of us who come from historically marginalized populations tend not to have that trust in government or in public health. Now, we also know, in terms of data needs and availability, that the technology we use to collect, aggregate, and report those data also makes it difficult to do certain things like add categories. For example, we know that for a long time, the state has been having conversations about adding a third gender category for things like unemployment or driver license or birth certificate. And sometimes it's a matter of policy, whether people are willing to do it, but sometimes it's a matter of technology. The system will not let us put another letter that's not S or M. And it's a bizarre and strange thing that we're still having to overcome those hurdles, but that is some of the challenge. We also know that antiquated technology makes it harder for us to share across agencies. And that also leads us to another related issue, which is personally identifying information and small sample size. That creates challenges with statistical weighting, which in the long run also hinders our ability to understand the full picture of what's happening. So that's a little bit on data. What you're looking at now is a screen that is extremely overwhelming, and that is a little bit on purpose. When we were, as a commission, working through some of the issues that we wanted to discuss in our first report, and really trying to understand the full scope and breadth of this work, it became extremely clear that it was a lot. It was a whole lot. And again, going back to the point that we wanted to do this right, meant that we were very intentional about wanting to take our time. Now, of course, we respect the legislature, and specifically that these committees have carefully and meticulously put together timelines that could assist them in policy making and budgeting. And we certainly don't want to step on that. But more importantly, we also don't want to step on the decades of advocacy work and policy work that has been done on these issues for years. And so what you are looking at now is the product of some of those brainstorming and issue mapping conversations, where we said, okay, what are some of the things that we want to be able to uplift in this work and in the next few phases of our work? And so that includes things like addressing the issues of trust and intergenerational trauma. It includes things like compensating people for their labor when we bring them in to tell us about their experiences or to help us think through good policy. Acknowledging history and incorporating traditional healing. Process equity, accessibility, staffing, and timelines and training. Because we know as a commission, we can come up with great ideas for policy, but are they going to be supported with the appropriate resources and given the time they need? We know that stakeholders in this work are going to include leaders and experts in transportation and housing and education, right? The upstream and social determinants. We felt strongly that we did not want to pit any groups of focus against one another, whether it was a community of people living with disabilities, the LGBTQIA+ population, people of color. We felt that, yes, we are all historically marginalized groups and have had varying degrees of problems with public health and with government. However, we felt strongly that it was a yes and wanted to make sure that we were moving everybody forward together. We talked about whether data include self-identified information or perceived information. For example, if I go to a doctor's appointment and they code me as an African-American person, they would have coded me incorrectly. Are our data accurate based on how people self-identify? And how are we accounting for the increased number of mixed-race people whose identities may not be as easy to spot from the outside? We talked about access to care, particularly for people who may use medical assistive devices. Are there Hoyer lifts in dentist offices, et cetera? We talked about access for the trans and gender nonconforming population, and how people's personal views and social views impact whether or not they are provided appropriate care. We talked about language barriers, age discrimination for youth and for older adults. We talked about some of the ways in which the work is siloed. For example, schools. And schools, really, that's multifaceted. One is the way that we teach health education in schools. And the other fork in that bifurcation is the way that we provide health in schools. For example, we have members of the commission who work as school health personnel, and they have shared that they are largely restricted just to acute care in schools. There is not really a mechanism for a more holistic and a more long-term solution for health in schools. Silos also exist with insurers, regulators, and providers, particularly when you consider the stratified federal and state issues around health. Of course, the carceral system is another area in which the work is very siloed. And I have to add that in the United States, because of course the United States, the name of the game here is mass incarceration, what we have now is not only a bursting prison population, but also an aging one. And so around the country now, we are having to retrofit carceral facilities to accommodate the older population of people who are incarcerated. And as we think about things like changing legalities, and I'm thinking about like the cannabis market and how many people have aged in place in jails around the country for something that now suddenly we're turning around and saying, oops, should have never been illegal. Let's figure out a way that we can help people make money from it. Well, let's also consider the health impact of those who had been harmed and incarcerated for it. And at the way bottom right there, you'll see a tiny one that says so many committees. And that's a big one, because while it's really great that we as a state put attention on a lot of issues, it's also important that we make sure that the work is as streamlined as possible. Can we accomplish in one group what we set up 3 groups to do? Are those 3 groups talking to each other? Is it an appropriate use of resourcing? And are we really getting a broad set of perspectives from all of them? So these are just some of the many issues that we were able to identify. I'm going to pull one quote from the report that I thought really highlighted this issue of pacing and timing, which says, because of the breadth and depth of these topics, the Commission has chosen to perform its work at a pace that allows for thorough research and meaningful community input. I stress that this was very important to the group, even with 29 of us who represent the Black and Latino and Asian and Indigenous and LGBTQIA+ population and people living with disabilities and people experiencing socioeconomic disparity and people who may be limited English proficient. Even with all of us together as 29 people, we still do not represent the entirety of the statewide constituency who we need to be thinking about. And so we're committed to doing this right, and that means both internal and outward-facing protocols. So that's pretty much where we are. And I will just add that of course, here are links to the report. We will add that there is a plain language summary and also an audio reading of plain language summary. Again, these are some of the measures that we wanted to take to make sure that the report and our work were as accessible as possible. So just to look a little bit ahead on the horizon, some of the work that we intend to do going forward is going to be hearing more from providers, and everyone has a different idea of what the word provider means. I suppose as I use it here, we're thinking of, yes, major hospital networks and policy people in healthcare delivery, but absolutely from people who are doing the work. We want to hear more from nurses. We want to hear more from EMTs. We want to hear more from crisis prevention workers and crisis intervention workers, I should say, and everybody in between. We also want to look more closely at what data are available, what data are missing, and how we can bridge that gap, and what's it going to take funding-wise to be able to bridge that gap. It's also important that we understand the demographic landscape of the state. Now that we have 2020 census figures, we can sort of keep looking ahead at who is going to be more reflective of the statewide population and being able to prepare for that. Another big thing here is being trauma responsive. For example, it's great that we're looking to have more people coming in under the refugee program. That is something that I am particularly excited about, but it's no use bringing people here who are already coming from a background of deep trauma if we're not going to protect them and care for them while they're here. And so looking at it from a multidisciplinary perspective to make sure that we're including not just health-related people, but everyone who is playing a role here. So I'll pause it there. Grateful for your time. And I would ask, of course, I'm available for any questions you may have, but also want to leave enough space for Mark and Andrea. Thank you.
Thank you. That was very helpful. And I think it resonates with many of us. The breadth and the depth of the issues that you are approaching are significant. And so I'll just ask one question, and then I think we probably should just keep going and listening. But as you're looking for data and information, it seems that if you're using the typical research bases that we currently have, there may or may not be supporting information for the work that you're doing. And so just as an observation, but what research databases have you utilized as you've gone through the reporting work?
Thank you for your comment, actually, because it does speak to another issue that I know we had this conversation a couple of weeks ago. Mark was present for that, where he astutely pointed out that a lot of the data we have were collected within a system that in itself is systemically biased and systemically racist. And so even being able not just to trust the numbers, but being able to trust the ways in which we collected it and the ways in which we're storing and grouping it is important too. And so we're all swimming in that same water. But to answer your question specifically, some of the databases that we use include the national data. Of course, we're pulling from federal work, and I'm showing here how much of a data nerd I am not, because there are some people on the commission are much better positioned to be able to explain that more clearly. But I will say that we have definitely a few people on the commission who are expert researchers who probably would be better at answering that question than I am. I will say, though, that we do have access to some of the more to some of the databases where access is limited, because we have state people who have access to certain, whatever it is, government data or healthcare system data, and that has been helpful. But we also don't want to rely on things that the public doesn't have access to either. So we're trying to, I think, use a good mix of qualitative data, quantitative data, and data that may not be publicly accessible right now, but that we can help make publicly accessible within, of course, applicable regulations.
Okay, thank you. I might link up with you again going forward, and we can maybe talk about this a little bit within our committee with you. We're bumping up on crossover, so it may not be right away, but I think it's something that is important. So thank you.
Yeah.
So I'll let you go ahead. You have the floor, Susana.
All right. So I see Andrea has come off mute. I'm going to take that as readiness.
Yes, please. Thank you. Kwai Nirombak, Uli Giskat, Uli Pamkeni. So that is hello, friends, and good morning. I am a native Vermonter. I represent the Cowasuk band. Thank you, Susana, for saying that correctly. And all of this as a fellow commission member, I represent Cowasuk, and I also try to keep the lens that it's all Vermonters, all Indigenous folks living in Vermont from that perspective. And we, as Susana did talk about the trust, we are in the middle of Black/African American History Month, and the theme this year is Black health and wellness. And so as we are also looking, as I'm looking at that in this lens for my testimony to you today, is we are looking, as Susana said, hearing from providers. Can we think about outside of the box for between not just Western medicine and other ways of knowing? And so looking at that data, how are we going to get that data? How are we going to have that trust? Because what I'm hearing from Cowasuk and other Indigenous folks, other Abenaki in Vermont, and as Susana pointed out, I present to my healthcare provider as white seeming. And even though I've put on the paperwork, I'm Abenaki, and that is, and then depending on who I have for a provider, I just recently had an interaction that I left feeling that they thought I was quote unquote crazy. And so these are the things that as I'm sitting on the commission, that for my hat, that I'm also thinking of for the community to make sure that we are being inclusive and representative of everyone in the state, for birth doulas, midwives, and not just within a medical facility like the hospital offering midwives, because it's still in a facility that looks like a medical model. I had my children at home with a team of midwives, women of color. And so I think about those things. So as we are talking about this health equity, access, and I also within my work, because I do work in case management at the hospital for folks who are and underinsured Vermonters. And I hear so many of these stories. So I'll leave it there. I don't want to belabor everybody. And hello, Ginny.
Hello, Andrea. It's good to hear your voice, even though I can't see you.
Yes, my camera seems to be broken. I'm working on that.
Okay.
Yes,
well,
yes.
But Andrea, thank you for your work on this. I know that you have a long history of working on this, and we're very appreciative of your helping the state resolve some of these issues. Thank you.
Thank you.
Susana, then is Mark Hughes next on the list? Does anyone, I guess a quick question then for Andrea. You know, I know that there are folks, for example, who work in the medical community with Indigenous folks. And in fact, my husband worked with some of the Indigenous people in Alaska for a few years. And so there must be some data out there that helps with the medical treatment for individuals from various tribal backgrounds or ethnic backgrounds that you've identified in the process. Has that?
There are, and there are a lot of that data, like you said, is Indigenous, not Indigenous necessarily to Vermont, to Abenaki. And Dr. Avila has provided data for various reports, not necessarily for our commission, but I'm aware of the data that she has available. And so I believe that some of that has been being used and is being used as far as the medical setting goes. Also working for the hospital, in that I see this is something that they are working on for DEI, diversity, equity, and inclusion, for whether it's onboarding the medical students, the residents, whether it will be ongoing training for cultural competency, cultural humility, that type of thing for providers, managers. It's seen, so as I come from that, in that lens here in this world, and again with the commission work, and my being an Abenaki Vermonter and representing Kawasuk, I trying to balance that to make sure. And then the question that I've had is the state expecting our commission to be the final content experts on these topics, when as a commission we are saying, well, let's slow down, let's make sure we have these necessary voices at the table, like Susana said, the folding chair, and not necessarily, even though I represent Kawasuk, I do want to make sure that we have the necessary voices, that we're hearing them and we're hearing their concerns, their ideas, and not just moving forward with the sort of that patriarchal model still of being the experts and we know best for everybody else. Does that answer your question?
This is very helpful, and I greatly appreciate it, because it helps to explain how the commission is working and the steps that you're taking to clarify. It is very helpful. In some ways, it sounds very much like the scientific process, but in other ways, it allows for some social and cultural interaction. This is really very helpful to all of us. Thank you.
You're very welcome. And I feel like we can't leave out the social and cultural aspects of health, because as Susana mentioned with the report, there is the historical trauma and so on and so forth. And folks are bringing that to the table as well. Not only are the individual members of the commission, the folks that we are thinking about for how this will impact for health and equity for the state, and how it is implemented in policy and legislation and everything.
Well, we actually look forward to receiving recommendations from you folks. And so for some of us, there's a little bit of disappointment that we don't have those in our hands, but this really helps us to understand the thoroughness with which you all are working, and greatly appreciate it.
Thank you. And I do have another meeting that I have to jump to. Do you think I'll still be needed, or will it be okay for me to jump off?
I think that's up to Susana. I think that this is helpful to have heard your comments.
Thank you, Andrea. I think if there's any other follow-up, I'm happy to connect with you offline, but thank you for being here.
Thank you. Adios.
Adios.
Mark, I see you off mute.
Good morning. I'm Reverend Mark Hughes. I am the Executive Director of the Vermont Racial Justice Alliance and Justice for All. I am also the principal of the Racial Equity Association, an LLC, and the head of a community center here known as the Richard Kemp Center, which is a cultural empowerment center here in Burlington.
Mark, could I ask for you to perhaps speak a little closer to your mic?
Yeah.
While I do that, how about if I go towards my system preferences and look for volume, because every now and then it sneaks away from me.
Okay, yeah, that would be great.
Let me see.
He was in the room as well. Thank you.
See if I can work on that. Boy, this is exciting. Okay, so here we go. Here we go. That's much better, isn't it?
Oh, absolutely. Thank you.
Everybody just go like this.
Thank you. That's much better.
So again, and for the record, again, I'm Reverend Mark Hughes. I'm the executive director of Vermont Racial Justice Alliance, also Justice for All, and an LLC called the Racial Equity Association. The Richard Kemp Center, which is here in Burlington, and also a minister at the New Alpha Missionary Baptist Church here, the only church in Vermont that worships in the African American tradition. So thank you for having me, and it's been a pleasure serving with the commission. It's interesting being a commissioner, being like now I'm a commissioner again. I was a commissioner with the police here in Burlington. Now I'm a commissioner again. I just thought about that this morning. So it's really good to see many of your faces, which I recognize, and I'm normally walking by you in the hallways in the State House. Just wanted to, give a shout out to Madam Chair and Mr. Chair over in the House as well. And thank y'all for the work that y'all did on what was H210. Our H210 was enacted as Act 33. And we were happy to be able to bring this work forward, this racial equity work forward. Obviously, we've segmented it in a way where we've envisioned it as work that was related to racial equity, but we put it forward in a way in acknowledging equity across all spectrums. Obviously, we do the work in racial equity. This is a part of a much larger strategy. And so what I'd like to do is just for a couple of minutes, explain to you part of that and talk a little bit more also about where we are in this process with the HEAC, more importantly. What I will say is it was our strategy to continue the work of community engagement and support. There's a lot of activities that we have, which include the work of the Kemp Center. And the reason why I'm framing this way is because there is a lot to do to address equity, not just policy, not just commissions. There's a lot of stuff that's happening, as you would know, outside of those commission meetings in across our communities and across various organizations across the state. So a lot of work, which includes the work that we're rolling out in the Richard Kemp Center, the outreach and education component of the work that we're doing, which augments your R113, which was your racism health emergency, public health emergency. The part of that is that a seminar we have called Turning the Curve. Various other outreach and education initiatives, abolish slavery. There's one on reparations in Vermont, the definition of systemic racism and the economics of systemic racism. All of these are ongoing. There is obviously a component that has to do with platforms and initiatives, which leads to our Acknowledge, Change, and Transform platform here at the state legislature, as well as our moral budget. And what we initiated last year is in addition to putting forward PR2, which you just passed over the last couple of weeks with the constitutional amendment, it also involved, obviously, as I said, R113, which was, I think, PRH 6 last year, the racism public health emergency, as well as H210, which what we're here to talk about right now, and H406, which is an economic and cultural empowerment piece that's now over in, I believe it's not finance, but
Ways and Means.
Somewhere in the House. We'll come back to that.
Commerce.
Oh, it's in
Commerce.
Okay.
Thank you, Rep. Tina. So the thing is that we've just got a lot of things going on that's directed, currently, with the geopolitical and economic implications of systemic racism. We believe that's, it's driving all things right now. And obviously, we appreciate the consideration that you're giving to this, and it is an integral component of the conversation that we're having within the committee. So I'll pause there for a minute. That was just the framing of how we got here and all the other stuff that we're doing as the Alliance. I want to talk a little bit more about the HEAC, but I just want to pause and just see if there's any questions that the committee has of me, or if there's anything that I just covered, but also in your limited time that you have left, which is maybe about, we're going to call it 10 or 12 minutes, in your limited time that you have left, is there anything that you'd like to hear from me in what it is that I'm going to be presenting here? Because I can just cut straight to the chase if there's something, Madam Chair, that you'd like to hear.
I'd like to hear your presentation first, and then
Right.
there may be a question or two, but go right ahead. Thank you.
Fantastic. So one of the things that I wanted to come and talk about is just to kind of echo what Susana said. And first, I want to give a shout out to my colleagues, Andrea, Susana. All of the stuff that we're doing together is pretty exciting. It's a lot. It's a huge challenge. It's a heavy lift. It's a lot of fun, and it doesn't go without it doesn't go without complications. So one of the challenges that we're having right now within the committee is just coming to terms with the fact that, in addition to all of the other demographics, we also have a demographic called government and non-government. And what that means is that there is a significant portion of folks within the committee that are government employees, which means they have access to the infrastructure like SharePoint, various other technology assets. They are collaborative by nature. They're at work all of the time. They're always logging in. They're always communicative with one another. And most of them, it's not their first rodeo. And many of them, they're senior in the executive administration, which means that sometimes if we're not careful, this thing takes unto itself a life of its own. And what it does is it kind of negates the whole equity adventure that we're trying to build within this process. So we've identified that as an issue, and it's unfortunate, but in my opinion, it was post-report that we've actually had the conversation on it. Personally, I'm appreciative of the fact that we were able to get you a report, but me, I'm fairly candid. I don't think that the report really it holds a lot of weight in my world, because what we were doing is we were meeting a deadline. I think the vast majority of the report, personally, it does contain a lot of findings, or I should say, it came from a conversation that we had prior to such time as we were able to really dig in. What we were doing was we just wanted to figure out what were the issues. So you'll see this thing called issues. And even with that, I don't know that they're comprehensive, and I don't know that we've really had a chance to dig into those, and they take up the vast majority of the report. And even looking through it now, me as being a member, and I'm pretty involved. There are things that I really didn't have a chance to even squeeze in there. So there's some challenges, because it's a really fast moving train, and it's really difficult and complicated for some folks who are community members to keep up with this process. Some of us are just trying to figure out how to log into SharePoint from time to time. So we're figuring it out, I guess is the good news. We are figuring it out. We've had the conversation. We'll continue to have the conversation. That I think the biggest highlight or the biggest takeaway from the report is the word preliminary. It is preliminary. We're here to report. We have provided a report. I think, and from my personal perspective, again, I think it's largely perfunctory. I'm not trying to discredit the work of my commission, because I respect all of my colleagues, but I'm here to tell you, from the perspective in which I've been operating in this process, I also sit on the policy committee. I sit on the data committee, and I also sit on the training committee, subcommittees of this group. I'm an integral component of what's going on here. This is very, very important to me. It's very important to the Alliance. It's unfortunate we didn't get across the finish line the HEAC that we wanted, that we envisioned, but we're doing the best we can with what we were given. And process is really, really important here. I would also say that there are things that, from your perspective, the way I see this process is with all due respect, I think there are some things that our policymakers and our executive branch and many others already know we must do. And what I would want to encourage you and just really implore you is please don't wait for us. Please don't wait for us to come back. Please don't sit back and wait. And I know you're very busy. I know y'all got 1,000 things going on, different directions. You're sitting on multiple committees and the whole 9 yards. Plus you have a life. But please don't wait for us to come back with certain recommendations. For example, we know that there is a huge need for a data infrastructure as we sit on an unprecedented budget surplus. as a state. We know that. We understand that this data infrastructure, it must accommodate these, tracking these disparities across various systems. And I think it's the heart and soul of everything that we're doing, not just from the racial equity perspective, but from an equity perspective across the board. So please don't wait for that. Please make the requisite investments in that immediately. Let's get the folks, just get a bunch of smart folks in a room and not let them out until they come out with a plan on how we move that forward. The other thing, it pertains to upstream. There's something that we refer to as upstream. One of the things that we believe, and I want to just give a shout out to Andrea for acknowledging Black history, is what we believe at the Racial Justice Alliance as it pertains to Black history, well, as it pertains to wellness. We have a wellness working group of which Rep. Chena is a part of, and there are many others who are across the community who are a part of this wellness working group. And it was through this wellness working group that H210 was born. It was through this wellness working group that a lot of activities have been happening, and we've discovered that we can't just talk about health because we got this thing called upstream. And here's what we said, and if you don't mind me quoting this, it says, our wellness is at the epicenter of all we do and experience. We must consider every action taken to dismantle systemic racism as an act of enhancing our wellness. We will disrupt status quo systems and develop long-range strategies for Black-led alternative approaches to create healthy outcomes. We will fight for wellness as if our life depends upon it, because they do. So I just wanted to share that with you because that is the perspective that we have. There is a lot of work that's happening in housing, in education, and employment, workforce development, economic development, transportation, and also the criminal justice system across all of these. And we know that we need to be working simultaneously. And this goes back to, please do the work now and don't wait for us. It goes back to the fact that we already know that policy and training, that and ongoing education, we already know that data and the infrastructure required to support it are very important across every single one of those aforementioned areas. So as you go back to your committees and you focus your time and attention on what it is that's important, understand that they too also come back to our wellness. And finally, I just want to go back to this conversation on funding. This bill, as Chair Lippert knows, and those in the House know well, the fourth or fifth thing that happened in its preparation for crossover is that it was stripped of funding, it was stripped of money. That doesn't mean if we see today that there is funding required in the initiatives that we are undertaking, that this joint committee shouldn't consider moving the necessary funding into place so we can do the work more effectively. Since we are in an unprecedented budget surplus, and this work is about wellness, not just for racial equity, but for all equity across the entire state. And it too is unprecedented. So I thank you for your time. Thank you for the opportunity to come before you. It's really good to see some of you, and I'll take your questions now if you have any, Madam Chair.
Thank you, Reverend Hughes. That was very inspiring, to say the least. And we appreciate the time and energy that you and Andrea and Susana have given to the commission. I do have a couple of questions, and I'll start with the budget at the end. So did the commission have a budget request, a line item request that perhaps went through the administration into the big bill, into the larger budget? That's one. Or do you have such a line item request that we could look at?
I don't want to assume anything on answering that question. I'm going to defer to our fearless leader, Susana
Okay.
Davis, on that one. Okay.
Okay, and I'll come back and ask another question, probably for both of you.
Madam Chair, can you repeat it one more time so that I can answer you concisely?
Sure, it's the comment was that the commission really doesn't have the funding it needs, and my question is, did the governor put in his budget any funding request for the commission that, based on your request? And whether or not that happened, do you have a budget that we could look at, a line item budget for the commission?
As a point of clarification, before she answers that, just so I can be clear on the record,
Sure.
what I was actually stating is in the event that the commission does require funding,
Got it.
we definitely need to know that that's available. And I think that we need to be preemptive in that respect, particularly since we know that money is available now, and work usually doesn't happen free. So I was just making some assumptions. So I don't want that question to go to Susana with that pretense that somehow or another there's something that we need that we have that we spoke about. Thank you.
So, okay, but I guess the question is, will there be a request? Do you have a request?
So to my knowledge, there is no item in the governor's recommended budget for the commission. The commission has the $180,000 allocation that this committee put forth last year to support the hiring of a contractor to assist in the work around standing up an office of health, or the recommendations around standing up an office of health equity. It is also from that pool that the commission members' per diems are being pulled. So that is an additional draw on that line item as well. What it does not account for also is any other kind of compensation that we may want to provide for people who are not commission members, who are performing labor, joining us, or doing any other kind of policy insight for us or with us. I can't necessarily foresee any space or equipment needs, but again, because we do want to be inclusive and provide physical accommodation, that is something to consider as we eventually go back to in-person meetings. Those are some of the things that I can think about. But again, I think that the commission, I agree with Mark that this first report is not necessarily the substantive depth we wanted to get into because we chose to be very intentional in not wanting to rush something, but still wanting to honor the deadline which we were given. But I will say that the budget conversations we do intend to have more deeply and more fully and come to you with well laid out recommendations on that when we have been able to give it the time and the attention they deserve.
Thank you. And this actually links with a comment I made earlier about data analysis, collection and analysis, and maybe hopefully during one of our committee meetings after crossover, we can get back and look at this a little bit together. I won't ask my next question. My other question, and something you can probably think about, is how do you balance all the issues and needs that you have in your commission? And then there are bills, as you said, Reverend Hughes, there are bills that are in the legislature now or will be put in, and we don't want to be business as usual and go catch as catch can, but on the other hand, the commission may wish to support some of these bills. So it would be helpful to know going forward which legislation would be important to the commission as a whole. So just those two things to think about. Representative Chena and then Senator Hardy.
Thank you. I want to start by saying that I'm actually not disappointed with the presentation today, because when we created this commission, the intent was for this commission to have greater autonomy than past groups. And we acknowledged how if we're going to change structural oppression, we need to empower people to do things differently. So for you to come to us and give honest feedback that your assessment is that the amount of work is so monumental that it's going to take more time, and the way you've sorted it, to me, it all makes sense, and I appreciate it. And I think we can be patient and give the group time and space and resources to do that work. I might have missed something earlier because I came late because I'm not feeling good today. So I don't know if I missed an update on the Office of Health Equity. I think I heard Susana Davis say that someone was contracted to look at moving forward with the plan to open it up. But if it was said already and you tell me that, I'll go back and watch the tape. But if it hasn't been said already, could you maybe take a minute to just explain kind of what we're looking at with that RFP and like, what the plan is? I have one other question too, I'll ask, and then I'll let Susana and Mark kind of decide how to answer. The second one is that considering that we're in the process right now of fine tuning the budget for 23. I am curious if either of you have any initial recommendations about areas where money should be spent right now. And I don't know if this is out of bounds, but like the healthcare committee has been looking at our recommendations. I would, at least as an individual, I would be interested in having you or a subgroup of the commission look at what we're thinking and give us some quick feedback. I don't know if there's a formal way to do that and have the committee, have people come in and testify, but I think there's little ways we can engage with the commission even before you're totally up and running. And one might be to see if there's a way you could look at what we're doing and just give us some feedback before we, finish our budget recommendations, for example. So I guess that question is sort of any ideas where money should be spent right now. And what I did hear from Mark is talking about the social determinants of health, but I'm just curious if there's any more detail. So I know that was a lot, but I think the two main questions are where are we at with the Office of Health Equity, and are there opportunities for you to shape our decisions as we make the budget by giving feedback and recommendations?
So let me just comment. Thank you for your questions. It's 10 o'clock. We're going to go a couple minutes over. And then Senator Hardy will have a question. And after that, we're going to end. I think as you're answering the question, please answer whether or not you are working with the House Human Services Committee, because they're also looking at social determinants. Just a thought there. But Senator, oh, no, not yet, Senator. Go ahead, Susana.
Thank you. So the first question about where we are with the Office of Health Equity, the appropriated funds to hire the contractor have not been used yet. I chose not to do that because while we were still setting up the commission, it basically just would have been me making that decision by myself, and I didn't feel comfortable making that decision on behalf of a 29-member group that had barely been impaneled yet. So I did not do that because again, process equity. So the answer is we are not anywhere with that. I think that it has taken this commission longer than expected to find itself and get its sea legs. And I also simultaneously believe that we are exactly where we need to be. So, that's where we are. We also do have, to the second point about budget, we have a subcommittee on grants and funding that has a number of people in state government and outside of state government who are familiar with RFPs, contracting processes, and the landscape of what exists. For example, one of the members on that subcommittee is somebody who works at the health department who is in charge of managing at least one, possibly more federal grant programs and CDC funded grants as well. So we do have a good picture of the landscape of what opportunities there are in the health funding landscape and also what to look for in this kind of an RFP. So we're looking for that group probably to lead on that. And to your point, Representative Chena, about whether there's an opportunity to jointly look at some of the recommendations from these committees, I think that would be entirely appropriate and appreciated by the commission. And I'm sure that we can figure out a formal or an informal way to funnel that information back and forth. I also want to apologize very deeply to this group. They are calling for me in Senate Natural, and I do need to step out, so I apologize for that.
Well, we're very supportive of the work that's going on in Senate Natural, so good luck. Thank you for being here and for bringing us the information. We really do appreciate it very much.
Thank you. And I do see that Senator Hardy does have a question. I apologize for not being able to stay and hear it, but of course I'm available if you wanted to follow up by email afterwards. I'm happy to speak more.
Senator Hardy, go ahead and ask your question, and then we can decide how to proceed. Go ahead.
Well, if Director Davis needs to go, that's fine. I will ask my question, but I can follow up with you also. So go ahead if you need to. I don't want to hold you up. But thank you for your work also. Yeah, so just thank you to Director Davis and Reverend Hughes and others who've worked on this. I think that we all knew when we were setting up this commission and doing the bill last year that it was a huge lift and a lot of work to do in a really fast time. But I mostly what I want to just say, because I heard Mark say something that I think is contradictory to what I've heard in the past from Mark. So I just want to just sort of lay out this confusion I have, and I think it's worth a longer conversation. So I don't want to have that necessarily now, but you said, please, I wrote it down, please do the work now and don't wait for us. And that is incredibly contradictory to what I've heard from you in the past. And I understand what you mean, but I also think we need to be really careful. You know, the whole not about us without us. I'm really just conscious that we don't do anything that gets in the way of the work. And as Representative China knows very well, he and I worked very closely at the end of last session to try to get all the language just right and the dates just right, and to make sure there was a timeline in there that spoke to the urgency of this work. So while I'm completely understanding and appreciative of the fact that it's super complicated and you need a lot more time to really work through it with such a big group and such a huge topic, I just want to make sure that we are our urgency and your urgency and our need for time and your need for time doesn't get confused, and that we are making sure that we're all working with best intentions. And so I just wanted to, that for me was kind of an elephant in the room, and I just want to say it out loud and know that this means we have to have a lot more conversations.
Senator, let me just say that is exactly what I meant by business as usual, where the legislature takes off and it's catch as catch can, rather than being built into a broader context. And so it's a great question. Go ahead, Reverend Hughes.
Yeah, just a brief response to that, because I appreciate you sticking around for a couple more minutes, is that, you know, actually there is no contradiction, because there's always been work that the legislature could move ahead on that they've been reluctant to. And I think if there's ever really been much contradiction from our perspective, is that there's a sense of urgency with folks who own political and economic power in times when they feel it's important. But when folks who are in marginalized communities believe that there should be a sense of urgency, then that's when folks with political and economic power usually have a tendency to put the brakes on. And I think contextually, that comment that was made, just for clarity, it had to do with those things that we know that we must do. In the example, the specific example that I used was this data infrastructure, for example. So the question that we might ask ourselves, just to completely round this conversation out, is why is it that in 2021, why is that the first time that we've ever decided that there was even a need for health equity? Why did we wait until 2021 to even make that decision, first of all? And then here's the second question. Why was it such an emergency that we have that report within 2 months after that, or whatever that time frame was? And I think what that does is it really clearly points out the contrast in who's setting the priorities and when. I think, you know, just to conclude on that and conclude with you today, unless there's any other questions, is that there are many things that are happening. Like, for example, H273 was on the wall last year, and we're finally making some progress on it. But why is it that it's taken us so long to move that? And why is it that we're still trying to, you know, play hot potato with H406, which is the economic development policy regarding, economic equity for Black and Brown and other folk? So there are a number of, you know, again, contextually, the whole upstream in all of the activities that are happening in other some of these communities upon which you serve, which is why I believed it was proper for me to state that, just so we can get beyond a health conversation, because wellness, as you know, it spreads broadly, is that there are things on the wall or things that have been in deliberation that have come forward. from us and other organizations that you are currently deliberating that there doesn't seem to be a sense of urgency on. And I would like to see, my hope is that as we do our work as a HEAC, as a Health Equity Advisory Commission, those things that we've already established to you as priorities, or those things that you already know to be priorities, I would just think that, I would hope that you would continue to move forward on. So as much as I appreciate Senator Hardy, the clarification that you sought and I hopefully provided, I think that, I think we want to just be careful of a slippery slope of making assumptions that Black and brown folks don't want you to do anything until we tell you to do. What we'd like you to do is we'd like you to do what you know or you must.
Thank you. And with that, we need to ask our visitors to leave this room. The Senate Health and Welfare Committee will stay here for a brief time. And thank you so much, Mark Hughes. And please give our best again to Susana and Andrea. This has been a very informative session and very helpful.
Thank you for having me, Madam Chair. And also I thank the committee, the full joint committee, and please feel free to follow back up with the other members directly if necessary, as well as myself.
Thank you. Okay.
Thank you.
All
Thank you
right.
very
So
much.
we end the joint committee meeting, and Senate Health and Welfare will stay right here.
Oh,
The data hub that we're talking about.
Claire,
we-
Claire, you need to kick your folks out. Yes. All right, getting there. There we are. Claire is still here. Does she want to be here? No. Okay. Phew. All right. Lauren is here. All right. Thank you, committee, for some patience with this. But so we'll hear from Lauren Hibbert. Lauren, thank you for being here. I know I reached out last week to talk a little bit about in particular, the mental health child certification stuff, and maybe more broadly, the peer-to-peer that we're looking at in 195, but mostly it's to look at what we might want to do with 197. So we're all mixed up here, but certification overall, and look forward to hearing from you.
Thank you. Thank you for having me here today. And I did file testimony with Aaron, I'm sorry to say, 25 minutes ago. So that's posted on the website if anyone wants to follow along. For the record, my name is Lauren Hibbert. I am the Director of the Office of Professional Regulation, and I appreciate the opportunity to talk about S-195, the Peer Support Specialists bill. And I apologize that I wasn't available on the day that you were taking other testimony. I was double booked in another committee, so I apologize off the bat. The Office of Professional Regulation is confident we can help assist with this bill, both through multiple different forms. We could either assist just from a policy perspective, or we could assist concretely with we could operationalize the program as well. As you know, we license and certify and register many professions in the state, and we have a lot of expertise in that area. We have the infrastructure to do that work. We also have the authority under Chapter 57 to do a sunrise review of a new occupation that is regulated by the state. And certainly that is what this bill is doing. And I think ultimately our ask on this bill is that we be allowed to do that work in conjunction with the grant work that is happening at DMH to prepare a fully cooked recommendation to the legislature next session. And I recognize that that is me coming in late to the party and saying, hold on, let's slow down and really think through some things. But my recommendation to do that comes from my experience regulating professions understanding that the core function of regulation of a profession is public protection. And inherent in that, there needs to be a couple of factors that I don't see in this bill. There needs to be defined qualifications. There needs to be a process for application approval and renewal approval. There needs to be a public list of who's certified so that someone can look up on a public roster. That's what we call it, a roster. Of, if you want to know if someone's a dentist in the state, you can look it up on our website and you can find out if there's been any discipline. There needs to be a complaint process, an investigation process, an enforcement process, a way to remove the credential. And I do think there's here, what this bill is doing is taking certifications that absolutely exist and should exist, but they're in the private space, the non-government space, and bringing it into the state space and giving it the state seal of approval, which I think is good work. It should happen most likely. I mean, just my gut is that this is a profession that should be regulated by the state. This should be a credential that is overseen by a government entity, whether it's Department of Mental Health or OPR. I'm a little more agnostic on. But there should be structure around it. And certainly in conversation with DMH, I will tell them that we have the infrastructure to provide. We could be a good state partner here. We have other programs where the subject matter expert department provides the policy decisions and we do the logistical decisions. I could see that as a path forward here. That's certainly not contemplated in this bill, but it does make sense to me. I'm not prepared to make modifications to this bill today to set that up. I really need to spend some time looking at how other states are overseeing peer support specialists, and I know that it's happening. So just from my brief research with my team, this is happening in 48 states, and it's happening in 3 distinct ways. It's one group of states is overseeing it by an office that's similar to OPR. That's the New Hampshire model. New Hampshire's doing it that way. Some states are overseeing it through their Department of Mental Health. That is a little bit what this model is, but not fully. And then some states are doing it, are contracting with a third party altogether, which I would say this bill is a mix between the last two models. And also not committing myself to this, but I think what we would find in a sunrise review, I want to do the work. I always like to do the work before I say what the opinion should be. So, but I do think there is risk of public harm here. This is the use of public funds for the provision of services. I've reviewed a lot of these programs, the online information. It does look like it could veer into the provision of psychotherapy, which requires either someone to be on the roster or to be licensed in or certified. We have certifications, registrations, and licenses in mental health. And if you're following along on the testimony, I have initial impressions and reactions to the bill. But in that section 1 at the top of page 2, you can see every profession that we currently regulate that touches on mental health. And I did include naturopaths, osteopaths, and APRNs, because they are certainly part of the constellation of the mental health care providers in the state, particularly APRNs, who there are specialty certifications in APRNs, psych APRNs. They have more specialized certifications than that. There's child psych APRNs. There's lots of them, but those APRNs are the closest there is to psychiatrists in the state. They really specialize in mental health treatment and prescribers. But so on the top of page 2 of my testimony is everyone who we currently regulate. We do not regulate any peer support specialists at this point. We do have the lower ADAP, the LADAC credentials, which are certifications and are part of the pathway towards a LADAC license. So I do see that there would be, again, not saying that this is what the report will say, but I can see that there is the need for the government to be in this space. This state has a very strong preference to not be involved in the marketplace of a regulated profession unless the state has a legitimate reason to be there. And then if the finding is, this is under Chapter 57 of Title 26, if the finding is the state does have a reason to be there, then the state is obligated to follow the least restrictive form of regulation possible. I think a certification of peer support specialists probably is the right place to land. But again, I want to do that analysis. And there is a lot of interplay with the mental health professions and Department of Mental Health and AHS. Currently in our statutes, there is preclusions for people who are working, providing mental health services in AHS programs. There is, if someone is or in a contractor for AHS, but there's certain parameters around that. There's also an exclusion currently in the majority of our mental health professions for peer-to-peer support. So, and specifically in the statute, it says peers counseling like AA and DV. So I'm aware of that statutory exemption, which on its face, perhaps this bill would fall into. But I am concerned that this bill was not the concept of that statute. That was not in the minds of the legislature when that exemption was created. And I don't think that particularly standing up an independent peer support office was contemplated. It was more contemplated in the structure of what I would consider more traditional soft peer support.
Because we're bumping up on our time, we need to be at a joint session of the House and Senate at 10:30, and I want to give folks a break. There's more here. We're learning a great deal more here than we've heard about this, and I'm wondering, okay, you're going to love this question about your availability tomorrow morning, and if we might schedule you in for a broader discussion.
I would love to be able to say I could be available at 11:15 tomorrow, and I'm sorry that I'm
that we're on the floor at 11:30 tomorrow. So that kind of well, there's no availability prior to that time. That's all I'm wondering. Like between no.
Really sorry, I don't have availability. I have my child's orthodontist appointment. If I try and reschedule that, it creates all sorts of headaches. So
we don't want to have a wait time problem. We get that. All right.
I'm really sorry.
No, don't be sorry.
I guess I still have to be a human and a mother. So that's
you have a life outside of everything else, and that's important. So this is all really informative and helpful. So we're going to have to, we did receive, at least Senator Hooker and I did receive a long memo from the Department of Mental Health. We just got it, and we're going to have to process that with our Ledge Council and with the committee. And the information that you have, I think, is also going to change the bill, at least 195, pretty significantly. So we should be staying connected with you on this. Okay. My my only question that I'm going to ask, because I know everybody wants to ask questions, we have a big discussion to go on here. We will try to schedule you in another time. Does that work for you next week sometime?
Oh, yes. Yes.
Okay.
I would love to be there.
Well, I think we have some time on our schedule and we'll definitely do that. It won't stop us from going through the DMH memo and looking at the bill with Ledge Council and perhaps having Katie reach out to you and get some interaction going.
Yeah, and just so the committee's aware, the drafters of the DMH memo and I and my staff
Okay.
attorney, Lauren Lehman, all talked yesterday.
Good.
And if you do have a conversation tomorrow, if you want OPR to be there tomorrow in the morning, Lauren Lehman could be there.
That might be helpful. And
Okay.
I think, Aaron, please reach out to Lauren Lehman and invite her in tomorrow morning. And then we'll see if folks from DMH are available as well. We need to have this discussion as a committee. Otherwise, because the bill is important to us, but all these bills are very important to us. And we know that there's a crisis out there, a mental health need, and we're trying to do whatever we can to move this along. So good, that would be helpful. I do
Okay.
have one question for you before you go to get your child ready for her orthodontics.
That's tomorrow, so I'm here.
I did send you information that from a couple of folks. I think it was Sandy Yandow, Lori Emerson, maybe it wasn't hers, but Sandy Yandow's and Sunny Naughton's on some peer-to-peer work that they do and the certification that they currently have under the umbrella of national organizations. And I'm wondering, I didn't see a comment on that, but whether or not those things are areas that can be listed on the roster for the work that they do within their workshops and so on.
Yeah, so what we would need to do if the legislature wants to add certifications to the roster is to add them as permissible certifications that we can issue. So what would happen is that person who's getting the third party certification would need to be on the roster, and then they can also independently say that they are, without the state seal of approval, say that they're nationally certified in X, Y, and Z. And there's the potential to add a lot of certifications to the roster or to any of our mental health professions. There's a lot of certifications out there in the world, not just on peer-to-peer, but EMDR, there's EMDR, there's, art therapy, music therapy. There's a lot of certifications that could be expressly added to our mental health chapters.
Okay, well, we may follow through with the few that we have been dealing with here. It does make a lot of sense to have some oversight of all of this, all the emerging new therapies and treatments. And I know you're acutely aware of this.
I am, and I just want you to hear me say, and I guess the public too, that I think this is a really important issue. I think peer support specialists are providing critical care in the fabric of mental health care now, and definitely should in the future. But from my perspective, if federal funds, state funds are being used, and particularly if there's the opportunity to act independently outside of a designated agency or outside of the oversight of AHS, then I think the statutory construction would, our current statutory construction and the principles of Chapter 57 would lead us to wanting an official state certification.
Will Laura Lehman be able to?
It's easy. She's another Lauren. So she's Lauren Lehman, and I'll forward her name to Aaron right now.
Okay, this is good. We'll continue the conversation in the morning. Thank you.
Thank you. And I apologize for not being able to be there, but you're in good hands with Lauren.
No, we'll be fine. And don't worry, we'll drag you back in. Thank you so much for being available.
Thank you.
Appreciate it.
Thanks, Lauren.
Yeah. So